So, how does chiropractic fit into healthy aging? Or put another way, how can we, with chiropractic care, reduce the negative impact of some of the more inevitable parts of aging? Remember, our aim should always be to help our patients. As mentioned before, the current focus on musculoskeletal issues and the recognition of the impact that they are having on society is really good news for us. We've also outlined how the population is aging, and what this will naturally result in is a number of older people coming to our offices with a number of musculoskeletal aches and pains. In this section, my aim is to bring you up to speed on how we interact with this patient population and how we can optimize their healthcare experience in a chiropractic office. We'll look at a variety of different parts of the literature to help us do this. My focus here will be on clinical research, including data on practice patterns, clinical trials, and some other information about what older patients expect out of healthcare providers. This information can really help us in clinical practice in our journey towards being a truly patient-centered profession. The balance of being an evidence-based practitioner is always the interplay between the best scientific evidence, your clinical experience, and integrating the context and preferences of the patient in front of you. This is not always an easy task, and it requires some commitment to understanding what the literature can tell us about various topics, in this case, aging and how chiropractic can assist older patients, but also putting together the experience that you have in your clinical practice dealing with this patient population. So let's get into chiropractic practice patterns with older patients. What do we know? Our colleague in Australia, Dr. Craig Moore, did most of his PhD work on looking into the epidemiological data and practice pattern data regarding which patients see us in chiropractic practice and what we do to them once they get into our office. This paper, published in the Australian Journal of Aging, was titled Characteristics of Chiropractors Who Manage People Aged 65 and Older, a national representative sample of 1,903 chiropractors. Not surprisingly, their main finding was that the majority of chiropractors do report treating older patients. Their findings called for better research to further understand the interactions between practicing clinicians and the aging population. Data from other sources show us that about 15% of patients that see chiropractors are over the age of 65. Not surprisingly, the most common reason they seek chiropractic care is for musculoskeletal complaints, similar to other age groups. DCs, depending on where you practice, may serve as first contact providers for some elderly patients. This naturally can change what your responsibilities might be in terms of monitoring different medical conditions or having to do more in-depth evaluation on a given patient over time to help liaise with other healthcare providers that may be farther away. A cross-sectional study published in 2015 looked at data from almost 18 million Medicare patients. This data was taken from 2010 to 2011. What it showed us was that the regional supply of DCs geographically might actually reduce primary care physician load for spinal complaints. In other words, having access to chiropractors can actually lessen the burden on the medical system, something that we'll talk a little bit more about later on. In this paper, it was estimated that chiropractic care could save 0.37 million visits to primary care physicians nationally at a cost of almost $84 million. We'll cover a newer study that looked at this concept as well in a few moments. In other words, and from another study, if chiropractors are available, older patients tend to utilize us, and again, this can have a massive impact on the burden placed on the healthcare system in general. This is one of the ways that we can benefit our patients and really contribute to an effective, efficient healthcare system. When we look at chiropractic utilization in general, the global median hovers around 9%. I think you would agree with me that there's a lot of room to grow there for us as a profession to have our maximal impact on the healthcare system. Data from the OCOAST study, published in my home province of Ontario by my friend and colleague Dr. Silvano Mior, looked at data from over 3,500 patient encounters. OCOAST stands for Ontario Chiropractic Observation and Analysis Study. Every cool study needs an acronym these days, and this one definitely checks that box. Regarding the patients in this dataset, 59% of them were between the ages of 45 and 64. That's probably not surprising, as this age group forms the bulk of most of our practices. For our purposes today, just under 20% were over the age of 65, and about 5% were under the age of 15, just to round out that data. The conditions they consulted us for included the regular suspects, including about 50% of them for low back pain, 15% for neck pain, 6% for low back and leg pain, about 1% for conditions that can be considered non-musculoskeletal in nature, and also less than 1% for maintenance care. This data has clearly shown us once again that patients most commonly consult us for musculoskeletal complaints primarily related to the spine. Regarding the treatments provided, about 72% received spinal manipulation. That's not surprising. 70% also received soft tissue therapy, 35% spinal mobilization or extremity joint mobilization, and about 30% involved activator methods treatment. Regarding how the patients got to the DC, this isn't just specifically to the older patients, we'll get to that in a moment, but it's interesting nonetheless. About 40% of new chiropractic patients were referred by existing patients. This is one of our best patient sources, and with a little practice management tip, it's the best way to grow your practice. Treat your existing patients well, and they will refer their friends, family, and colleagues. 13% came from internet referrals or friends and family other methods, and under 7% came from MD referrals. On the flip side of that, less than 3% of chiropractic patients were referred to an MD. This can reflect the fact that most patients may not need to be referred to an MD for further evaluation, but it may also represent an area of clinical practice where we can improve our interprofessional collaboration and communication. This data was also similar to the Australian COAST project, and we'll integrate some of the data from older patients in this next slide. This study was published by my friend and colleague Dr. Katie DeLuca, and it combines data from the Ontario and Australian COAST projects, looking specifically at the data relating to the patients who were 65 years and up who consulted chiropractors. There were 867 unique patients in this dataset, representing about 16% or 1 in 6 of the chiropractic patients in the entire dataset. Only 5% of these patients were over the age of 85, representing about 1% of all chiropractic patients. Based on what we've talked about so far in this course, the number of patients over the age of 80 or 85 that consult us as chiropractors is surely to increase. So this is a patient population we should try to become more comfortable with to serve them properly. The diagnoses for these older patients in the COAST and OCOAST datasets were similar to the global dataset, including low back complaints in just over half of them, neck complaints in 10%, back and radiating pain in 5%, a muscle problem and shoulder problems and lower limb problems at 4% each, and health maintenance as a general diagnosis or reason for seeking care in just under 2% of them. As you can see, there's a general mix, but it's also quite representative of the data we see for all ages of patients that consult chiropractors. The treatment techniques utilized broke down in a similar way as the other dataset as well. However, this time, soft tissue techniques were the most commonly employed at 85%. Spinal manipulation was utilized in 60% of patients, activator in 43%, mobilization 42%, drop piece 26%, exercise was 29%. That should be a lot higher, as we'll talk about later on. Flexion distraction was 7%, and acupuncture rounded out the list at 6%. This paper gave us an interesting glimpse into the specific data relating to the care of older people in a chiropractic office, looking at a total of almost 8,000 patient encounters and resulting in analysis, like I said earlier, of 867 patients over the age of 65. This is the largest data set we have on this age group to date. Let me just be clear about what I mean when I talk about chiropractic care. In the literature, it's easy to boil down a chiropractic appointment to receiving spinal manipulation only, for example. It's always been my opinion that we can offer so much more to patients, and I hope to illustrate that for you in the remainder of this section and the other sections in this course. The treatment and the potential impact you can have on patients starts as soon as they walk into your office, and this relates to the contextual factors that we spoke about earlier in the course. Further, we all provide different mechanisms of treatment and integrate different treatment modalities to make their individualized treatment plan fit them and their clinical condition and suit their needs, desires, and outcomes that they're looking for from chiropractic care. So I just wanted to briefly mention that to remind you that everything you do with a patient from the start of their appointment to the finish and everything in between is an important part of chiropractic care. Let's move on now to talk about spine pain in the elderly. So what do we know about spinal pain in the elderly? We've known for a number of years now that neck and low back pain are the leading cause of disability around the globe in adults of all ages. Back and neck pain are also common in elderly people, and they often occur together. Both are associated with significant disability, which can negatively impact general health, functional independence, and quality of life. We also know that chronic pain and chronic musculoskeletal pain is associated with an increased number and chance of having comorbidities. Most commonly, these comorbidities, as I outlined earlier in the course, include cardiovascular disease, diabetes, widespread pain or multi-site joint pain, obesity, reduced cognitive function, which can have a real impact on elderly patients, increased risk of falls, which we've also discussed in this program, and kinesiophobia. Kinesiophobia is particularly important because if an older patient is afraid of moving, they're less likely to exercise, they're less likely to participate in rehabilitation activities that you prescribe for them, and it's just a mechanism by which their health can generally deteriorate. Getting our patients moving is a primary take-home message from this course, and it's critically important for patients of all ages. The World Health Organization has identified low back pain as the major disabling condition in older persons. This can include general back pain, osteoarthritic changes, or lumbar spinal stenosis, both of which we'll talk about in subsequent sections of this course. As I said earlier, we've known that low back pain is the main cause of years lived with disability since 1990, and the numbers are increasing in a very concerning way. Low back pain in the elderly is associated with reduced mobility, reduced social participation, increased isolation, and difficulty conducting and performing their activities of daily living. All of these can have a negative impact on overall health-related quality of life in this patient group. The next couple of slides contain some additional points from the literature on older patients. We know that 21 to 68% of older patients experience low back pain episodes in a 12-month time frame. Older people with low back pain also have increased pain and disability relative to younger people. What goes along with this is an increased chance of non-recovery and poor outcomes. We know that 70% of years lived with disability affect working age people. That's generally considered between 20 and 65 years of age. Where this plays into how we deal with older patients is that years lived with disability resulting from back pain can force some people into early retirement. This has massive negative downstream consequences on lowering wealth, socioeconomic status, physical activity, fitness, general happiness, social isolation, and all of the other factors that we've talked about so far in this program. Regardless of the age of your patient, it should always be our goal to keep them working as long as possible as they're getting older, but even for younger patients to keep them on the job to prevent these negative outcomes. We also know that older people seeking care for low back pain more commonly receive ineffective or harmful treatments. Isn't that horrible to think about? This includes an increased inappropriate use of opioid prescriptions, spinal injections, and surgery. This is when comparing what younger people receive, and we'll talk more later about guideline concordance and how the medical profession is kind of screwing this up and how we can be of assistance. We also know that older adults with low back pain are 50% less likely to be recommended spinal manipulation or exercise compared to younger patients, both of which are major components of existing clinical guidelines for low back pain. In other words, older people are simply treated differently than younger people when it comes to low back pain. This is a mechanism by which chiropractors can have a major positive impact on the healthcare system. We also know that access to chiropractic care varies geographically, and it is very likely that we're underserving this older population. As I've said earlier, this will only get worse over time and represents yet another challenge for our profession to make sure there are enough chiropractors to serve this patient population and all of the other people that we work with. Further, there's also evidence suggesting that older adults with low back pain are less likely to seek or receive care for their condition compared to younger people. A paper published in 2015 looked at beliefs and healthcare seeking behavior related to restrictive back pain and found that it was influenced by a number of factors. First, patients reported that the clinician's beliefs about their back pain were critically important, and they didn't like the fact that a lot of medical doctors would report that their back pain was inevitable or because of their age. As we talked about earlier in the program, blaming someone's condition on their age is typically not received very well by our patients. We also know from this study that patients themselves generally hold negative attitudes towards drugs and surgery, the more invasive techniques that are used to treat spinal pain. The patients also felt confused and even felt that their medical practitioners were a bit confused about the relative importance of their spinal pain condition in the context of all of the other healthcare conditions that they might be experiencing. As we've covered, older patients can simply present as more complex clinical cases that need to be managed in a different way. Sometimes pulling out the exact contributions of their symptomatology pattern related to the different conditions that they might have is a challenge both clinically and from a diagnostic and prognostic perspective. Let's shift into discussing risk factors for back pain in a moment in older subjects. Risk factors are kind of tough to study, and ultimately, regardless of the age of your patient, they can be individualized to the person sitting in front of you. However, in younger patients, the risk factors for low back pain have been a little more well established. A recent systematic review and meta-analysis published in 2021 looked at risk factors for low back pain in older patients specifically. This study included 10 studies with over 31,000 subjects. What they found was that the 12-month prevalence of chronic low back pain in those over the age of 60 was 36.1%, which fits into that range that I mentioned a few moments ago. Multiple risk factors, 28 in fact, were associated with low back pain. All of them were derived from limited evidence, however, and I'll go through them in a moment. Of note is that one factor was actually protective from development of chronic low back pain in older patients, and that was intermediate leisure activity. Once again, keep your patients moving or encourage them to move more tomorrow than they move today. So the findings of this systematic review and meta-analysis were as follows. You'll see the highlighted portion on your screen. 28 and 1 factors were associated with a higher prevalence and a lower 5-year cumulative incidence of chronic low back pain, respectively. No prognostic factor was identified. There was very limited to limited evidence that females, obesity, anxiety, depression, mental disorders, self-expectation of recovery, self-perceived health status, lifestyle including smoking and daily fluoride consumption, previous falls or lower body injury, retirement or disability due to ill health, a family history of body pain, comorbidity including knee osteoarthritis or chronic obstructive pulmonary disease with or without hypertension, weak abdominal muscles, leg pain intensity, widespread pain, pain interference on functioning, use of pain medication, occupational exposure including driving for over 20 years, or jobs involving bending or twisting for over 10 years, disc space narrowing, and severe facet osteoarthritis were significantly related to a higher prevalence of chronic low back pain in older adults. There will be a quiz on this in just a moment, and you have to remember all of them. I'm just kidding. However, very limited evidence suggested that intermediate level of leisure time physical activity was associated with a lower prevalence of chronic low back pain in older adults. As you can see, the list of potential risk factors for the development of chronic low back pain gets a little bit convoluted for older patients. However, each of those factors on their own make logical sense. Once again, deal with the patient in front of you to see what might matter to their history of spinal complaints. Before we move on, I wanted to highlight a really interesting paper that was just published. In fact, we've done a research review for this paper on RRS Education. This paper looked at chronic low back pain and brain aging, something that is of increasing interest in the research literature. Chronic low back pain is generally associated with neurodegenerative changes in brain structure, potentially leading to impairment in attention, mental flexibility, language skills, and emotional decision-making. This study used advanced imaging and machine learning and compared 31 non-depressed patients with chronic low back pain to 32 healthy controls. Their findings were really interesting. Chronic low back pain was associated with greater brain aging, including changes in gray matter density in multiple brain regions. This became more profound later in life. The authors estimate that having chronic low back pain added 1.8 months extra to brain aging per year of having the condition. There are similar findings in other chronic pain patients as well. We know now that chronic pain changes the brain, but this study brings it into our world of low back pain, and like I said, it's simply a fascinating way to look at it. Chronic low back pain and depression also create similar brain changes, and what this study showed us is that chronic low back pain can create these changes in the brain in the absence of depression. Remember, the 31 subjects that they used had chronic low back pain but did not have depression. That's also an interesting finding from this study. Let's move on now to the chiropractic research relating to spine pain in older adults.